a very stimulating session and all the speakers. It's my pleasure to introduce Dr. Michael Spear now. Dr. Spear is the past chair of the Texas Collaborative for Healthy Mothers and Babies and is a full-time neonatologist and medical director of the Neonatal Nurse Practitioner Program at Texas Children's Hospital and professor of pediatrics and ethics at Baylor College of Medicine. Dr. Spear graduated from Baylor in 1968, completed his residency in pediatrics and fellowship in neonatal perinatal medicine at the same institution. He is board certified in pediatrics and neonatal perinatal medicine and has been practicing medicine for 37 years. Dr. Spear, the floor is yours. Dr. Spear, you may need to unmute.
Can everybody hear me?
Yes, we can. Thank you.
Excellent. I have the pleasure of introducing Dr. Jennifer Schuford, who is a chief state epidemiologist for the Texas Department of State Health Services. In that role, she serves as provides leadership for data-driven activities and policy formation. And without further ado, she is going to speak with us, future considerations, allocation, and distribution of the COVID-19 vaccine. Dr. Schuford.
Hi, y'all. Thanks so much for being here today. And it is awful to have to go behind all of those wonderful speakers that just went before me, but I'm happy to be here talking to you today. So I'm Jennifer Schuford. I'm an infectious disease physician by training, but I've been at the state health department for the last 3.5 years and love being able to practice public health. So next slide, please. I'm going to jump right into some of the epidemiology of COVID in Texas, and so that you'll have a kind of a baseline of why we're doing any of these activities. And so if you see on this slide, these are new cases of COVID-19 by day. So across the x-axis there, you've got days. It goes from June all the way until now, and up along the y-axis, new cases per day. And you can see we had that first peak back in July. It was really worrisome and really stressful to our healthcare system. And then what you can see is that we had some improvement as we made our way through summer and into fall, but we never quite got down all the way to our baseline. And lately we've had a second peak about within the last month. And so before, we were seeing just over 10,000 cases per day at the peak during the summertime, but we were seeing over 20,000 cases per day during our most recent peak here in January. Next slide. And so this slide shows hospitalizations over time and is less impacted by the availability of testing. And what you can see again, though, is that we had that peak back in July where we had over 10,000 people in the hospital with COVID-19 at one point there in July. Now, again, we came down, but we never quite made it all the way back to our previous nadir. And so then we started to take off again and had a recent peak, our second peak here within the last month in January. And where our peak during the summertime was about 10,400 cases, in January, we made it over 14,000 hospitalized COVID-19 patients, again, stressing our healthcare system. We're seeing downward trends now, which is fantastic and being seen in most states across the country. But what we're seeing is that even when we dipped down, we weren't able to get those staff. So the state is still paying for about 10,000 healthcare workers to be in hospitals across the state for all the reasons that we've already been talking about, that staff were getting sick and couldn't be there, and patient loads were going up. And so even when we dipped down, we weren't able to demobilize a lot of that staff, and now we're at a new peak. All right, next slide. And following, obviously, cases and then hospitalizations is fatalities. And so we were seeing over 300 fatalities per day back in July at that peak. At our more recent peak here in January, we were seeing, and into early February, seeing even over 400 deaths being reported per day. And so it has really taken its toll on Texas. Next slide. And so, through this, though, what we've noticed, and that I know y'all have heard about, is that COVID-19 has not impacted all populations similarly. There are populations that are bearing a disproportionate burden. And so we know that people of color have a disproportionate amount of the severe disease and death here in Texas and across the United States. We also know that people with underlying medical conditions, things like diabetes or cancer or heart disease, COPD, obesity, they're at higher risk of having severe disease and death. And those older people, so 65 and older, also at higher risk. But what we've also noted, and Dr. Epps has already covered, is that pregnant women, there's research that supports that pregnant women also fall into that category of being at risk of more severe disease. And so this is that MMWR article that she was talking about, where it was first published in June, and then they did an update in November, showing that even after you adjust for age, race, ethnicity, and underlying medical conditions, that pregnant women, when they were compared to people of the same similar women who were not pregnant, they were about 3 times as likely to be admitted to the ICU, about 3 times as likely to need invasive ventilation, about 2.5 times as likely to receive ECMO, extracorporeal membrane oxygenation, and about 2 times as likely to die. So here we have pregnant women falling into one of these categories that puts them at risk for more severe disease, and groups that we would be worried about. So ideally, when vaccines are developed, we like to prioritize populations that have these higher risks of severe disease and death. And it would be nice to be able to put pregnant women in that group, but we were lacking data at the time. Next slide, please. I'm just going to talk a little bit about the landscape of vaccines as it is right now and where we see it going soon. And then we'll come back to vaccination in pregnancy or during it for lactating women. So these are the 5 vaccine candidates that either have an emergency use authorization already or are well along into their phase 3 clinical trials and have a contract with Operation Warp Speed here in the United States. And so those first 2 are the mRNA vaccines that you are likely very familiar with. And so this mRNA vaccine technology is new for us here in the United States. Obviously, a lot of research had already gone into it, but no FDA-approved vaccines using this technology. And so what it does is use a little segment of messenger RNA that's inside of a lipid nanoparticle, and so that it gets taken into the cell. And then that mRNA can be translated into spike protein and presented on the surface of that cell, and so that the human body can form an immune response to it. So that's how that technology works. Now, the problem with these mRNA vaccines is that they're really fragile. It's temperature labile, and so it's difficult to handle them. And so the Pfizer vaccine in particular has been really problematic, requiring that ultra low frozen temperature, a requirement of -70 degrees Celsius storage. It's nice that it can be stored up to 6 months at that temperature, but only refrigerated for 5 days at refrigerated temperatures. And so it has been a challenge to use that broadly. Now, this particular vaccine, both of the mRNA vaccines, are 2-dose series. And so Pfizer is at day 0 and day 21. And, they were able to file for an emergency use authorization and were granted that for ages 16 and up. And the fantastic news is that they're already doing trials in children all the way down to 5 years old. So we might have expanded age ranges soon for the Pfizer vaccine. And the other terrific thing about Pfizer vaccine is that their vaccine efficacy was about 95%. That's the numbers that they presented when they applied for an emergency use authorization, and showed that efficacy was true across age groups. So very encouraging, considering that the FDA had set the floor at like 50% vaccine efficacy. And so really encouraging to see one that was very effective. Now, adding complexity to these vaccines that are being rolled out is the emergence of variants around the world. So variants are those mutated strains, and there's a few variants of concern that we're trying to keep a closer eye on. And so this Pfizer vaccine, they did test it in a lab to a lot of the mutations that are seen in the UK variant, and showed that it retained its vaccine efficacy, but we're not really sure how effective it'll be against a lot of these other variants. Now, the Moderna vaccine is very similar to the Pfizer vaccine. Another mRNA vaccine is a little easier to deal with because you don't need those ultra low frozen temperatures. It can be kept in a refrigerated setting for longer. It too is a 2-dose series, which is just kind of hard to deploy in general, but it's at 0 and 28 days. So of course it's a different interval than Pfizer, just making it a little more complicated. It too already has its emergency use authorization down to 18, but they too already have trials going on looking at this in kids down to 12 years old. And so we might see expanded age range for the Moderna vaccine soon too. And the Moderna vaccine reported a 94% vaccine efficacy. They showed a little bit of decrease in efficacy for older age groups down to about 84%, but still really effective vaccine. Moderna, though, it has been noted that Moderna appears to have little less efficacy against that South African variant, which is B.1.351. And they are already working on a booster to address that particular variant and other ones that might share some of those same mutations. And so even though it's a little bit painful to be thinking already about another round of vaccination, at least they are working on that even as we speak. So the next one down is that Johnson & Johnson vaccine. Now this is an entirely different platform. So they're using a viral vector. They have got a non-replicating adenovirus that they're using for this particular vaccine. And so the adenovirus, like I said, it's not supposed to replicate at all. It just is the vector to get that piece of genetic code from SARS-CoV-2 into a human cell. And once it's in there and gets in the nucleus, then it can be transcribed and translated into spike protein, which then goes out to the cell surface, just like we saw with the mRNA vaccine. So that spike protein is on the cell surface and it allows the human immune system to form a response. And so that's how those viral vector vaccines work. Now, these are a little bit easier to deal with, frozen for up to 2 years and refrigerated for up to 3 months. And the great thing about this Janssen vaccine, like that's everyone's heard about, is that it is a 1-dose vaccine. And so, there's real benefit to that, but there's also perhaps some downsides. And so Janssen reported when they filed, maybe right before that, for their EUA, that there was about a 66% vaccine efficacy about 28 days after that 1 dose. And so it's a little lower than what we were seeing in other vaccines. And when they looked at it across countries, they said, for the United States, it was about 72% vaccine efficacy, but in Latin America, about 66%, and in South Africa, about 57%. And so what they were probably noticing is some of the contribution of variants in those locations. But still, even in the United States, 72% vaccine efficacy is lower than what we were seeing with those mRNA vaccines. It could be related to the fact that it's a 1-dose vaccine. So they already have ongoing trials as a 2-dose series to see what happens with their vaccine efficacy with that. Now, they have filed about a week ago for an emergency use authorization. FDA is scheduled to meet with their vaccine advisory committee on February 26th. And at that point, we'll probably have a little more information ourselves that we can look at. And those are public meetings, and so you can even listen in. And they have filed for ages 18 and up. So we'll see if an EUA is granted in this case. If so, ACIP will meet right after that, and we'll probably then expect vaccine about the first week of March for Janssen. They haven't, there might not be a lot of vaccine immediately available. There will be some, maybe 8 to 10 million doses for the United States, but they expect to be able to ramp that up quickly. All right, so the AstraZeneca vaccine, this too is a viral vector, an adenovirus. It's just a chimpanzee adenovirus that they use for theirs. It can be refrigerated for 6 months, so a little more stable, which is nice. It is a 2-dose vaccine as well. at 0 and 28 days. But if you've been paying attention to the news, you know that in the UK, they're actually using a different interval. And so, and AstraZeneca has published some data saying that even with that extended interval, what they were seeing is about 76% efficacy after their first dose, and then about 82% efficacy after that second dose, even when it's spread out by 12 weeks. And so there might be some flexibility in that dosing interval that they're seeing there without losing a lot of efficacy. They have already have emergency use authorization in the UK, and so it's actively being used there. We expect that they'll probably file here in about April. And so we'll wait and see if that really plays out the way we expect to, because they too have noticed a decreased efficacy in South Africa for mild to moderate COVID-19. And so South Africa has halted use of the AstraZeneca vaccine. So yet another example of how these variants are emerging and impacting some of our plans that we've already kind of laid, and that might have to be changed up a little bit. As far as the Novavax, and so that's down at the very bottom of this slide, it is a different technology altogether, a recombinant subunit, protein subunit vaccine, which includes an adjuvant. And so in this case, what they do is that they use genetic code from SARS-CoV-2, but make the spike protein in insect cells. And then they harvest those proteins, purify them, and use a nanoparticle to make it a virus-like particle before they inject it. So it is just protein. There's no live virus, there's no genetic code, genetic sequences going in to a person's arm. So I think some people will feel more comfortable with this, even though it does have an adjuvant. It's a little more stable too. It can be refrigerated for 3 months. It is a 2-dose series like most of the other ones, spaced at 0 and 21 days. They are in phase 3 trials. They just released some data about a week or a week and a half ago that showed their vaccine efficacy in the UK was about 89%. That was from phase 3 trials in the United Kingdom. And so their efficacy of 89%, when they split it out and looked at vaccine efficacy against the UK variant against other wild type circulating SARS-CoV-2, what they found is that the vaccine efficacy for the variant was about 84%, and for the wild type was about 94%. And so again, you saw the impact there. And they went ahead and publicized some data of their vaccine in South Africa clinical trials, and showed that in South Africa, they had a vaccine efficacy of about 60%. And when they looked at those, were able to sequence the viruses that had actually caused infections in the vaccinated individuals, what they found is over 90% of them are that South African variant. And so again, we're seeing impact of these variants, and but Novavax is already trying to address that as well. Next slide. What I didn't say though is that even with the limitations there, it is amazing that a process that usually takes like 10 years to develop these vaccines and get them approved, they've been able to do within a year. And granted, it's been with a lot of support, a lot of monetary support by the US government, but they have done really remarkable things, and with brand new technologies, just taking us to a new level. So it's been an exciting time to kind of watch those developments play out. But one thing that a lot of these, these clinical trials did was exclude pregnant women. And like Dr. Epps was mentioning, there was a lot of advocacy going on from ACOG and the Society for Maternal Fetal Medicine at these committee hearings committee meetings that I had even listened to. And they were very vocal in support of allowing access of pregnant women to these vaccines. And so, as you know, they were not excluded from the recommendations after the fact. This is the CDC clinical guidance that's come out about these mRNA vaccines. And they're pretty upfront about the lack of safety data for COVID-19 vaccines in pregnant people, and then do lay out some of the evidence, which I think is really helpful, talking about using the Moderna vaccine in rat studies, and that there weren't any safety signals that they noted in those studies. that manufacturers, even though they excluded pregnant women from the study from the beginning, obviously people get pregnant during vaccine trials, and that these manufacturers are at least following out those pregnant women to see about outcomes. And that studies in pregnant people are planned, and some have been highlighted even here. Experts believe that mRNA vaccines are unlikely to pose a risk to a pregnant woman or a fetus, just highlighting that mRNA vaccines are not live vaccines, and that this messenger RNA is really degraded quite quickly when it gets into the cytoplasm of the cell, and it never enters into the nucleus. And so giving the recommendation that pregnant women may choose to be vaccinated if they're part of a recommended group. And that discussion with the clinical team is encouraged but not required, where the WHO guidance kind of pushes a little more and says that it should be in consultation with the clinical team. Here, there is some latitude for a woman to make that decision. Now, Moderna has taken an extra step and set up a pregnancy registry, and are encouraging women who are pregnant to get the vaccine to go ahead and register with them so that they can follow them through their pregnancy and after birth, and to collect a little more data about effects in pregnancy. Next slide, please. For lactating women, the guidance is very similar, just saying there's no data on safety of COVID-19 vaccines in lactating people, their infants, or in milk production, but that mRNA vaccines are not thought to be a risk to the breastfeeding infant. And so lactating people may choose to be vaccinated if they're part of a recommended group. Next slide. And they go so far as to even include it. They have this chart at the bottom of their clinical guidance showing people that may proceed with vaccination, people in whom there would be a precaution to vaccination, and people in whom there is a contraindication. And what you can see is pregnancy and lactation were very clearly included in that green column of may proceed with vaccination. Unfortunately, this whole chart changed over the last 48 hours on their website, but the meat of it is still the same and the text is still the same. That pregnancy and lactation are in no way a precaution or a contraindication to proceeding with vaccination. Next slide. So, but this is, anytime that we encounter one of these data-free zones or data deserts, it's a good time or absolutely necessary time for shared decision-making. And I think there's some considerations that should be included in those discussions when there is that shared decision-making going on, including the level of COVID-19 community transmission. So this is just a way of kind of quantifying the risk of exposure. And, if there's no COVID-19 circulating, then, the risk of the vaccine might outweigh the benefit. But, as we've seen lately, there has been plenty of SARS-CoV-2 circulating, and people are at risk in our communities still. A patient's personal risk of contracting COVID-19. Are they a healthcare worker? Are they a retail worker where they're in constant contact with other people? Or are they somebody that can just hole up in their house and really remain pretty isolated? The risks of the COVID-19 to the patient, the potential risk to the fetus, the efficacy of the vaccine, side effects of the vaccine, including fever, like we see with very commonly with the mRNA vaccines, and a lack of data about vaccine during pregnancy. All right, next slide. Now there is this tool, and there are others that are available. This one I thought was good. It is from University of Massachusetts, Bayview, I think. Anyway, they developed this tool and it's available online. I give the reference down at the bottom. And it's to help a pregnant woman and her healthcare provider to kind of walk through what needs to be considered. And women can even use this alone at home to kind of get their brain around this decision that they're trying to make about what are the options, what are the benefits of getting the vaccine, the risks of getting the vaccine, and then what do experts recommend? So I think this could be a really useful tool, especially when you're in those patient encounters. Next slide. But whether or not somebody gets the vaccine, there are ways to reduce risk. And even with the vaccine, we would still encourage anybody to continue these preventative measures, including wearing masks, especially when you're with people that aren't in your household and you can't avoid being close to them, avoiding other people who don't wear masks. trying to stay physically distanced from people by at least 6 feet if they're not from within your household, avoiding gatherings where it's hard to maintain that separation, washing and sanitizing hands, and limiting interactions with people who may have were exposed to COVID-19 or might have it. Next slide. So here in Texas, Dr. Allocation serves on the expert vaccine allocation panel with me, and we're very clear that pregnancy belonged in one of those risk categories. And so you can see that even though the "we are here" sign points over a limited supply, that we've included pregnancy in that group 1B. And so pregnant women are currently eligible to receive the limited supplies of vaccine in Texas. And that 1A included like healthcare workers, patient-facing healthcare workers, long-term care residents, long-term care workers. And then 1B is those 65 and older, those other underlying medical conditions of pregnancy. So that option is open to pregnant women in Texas. Next slide. So this is just a screenshot of our vaccine dashboard on our DSHS website. And this is from about a week ago. And this isn't the only view that we've got. We've got multiple. And so if you want to kind of watch how a vaccine is being rolled out across the state and how much different counties are getting either by numbers or per capita, you can look on that dashboard and get that information. Though for today, we just updated it about noon, and it showed that about 2.8 million Texans have gotten at least one dose, and about over 1 million Texans have been fully vaccinated now. So that's between 3% and 4%. So we're making a little bit of headway. We've got a long way to go, but we're getting there. So next slide. And that is it. I am happy to take any questions though.
Okay, Dr. Schufert, this is Dr. Spear. I have a couple questions for you.
Sure.
Number one, is there any research being done on whether any of these vaccines affect fertility or reproduction?
They are, and I've just heard though that generalization that they are looking at fertility, but I can't tell you exactly where that's happening or what the study protocols look like.
Okay. Second question, why are a lot of vaccines being given 3 weeks apart if that isn't the recommendation, or 2 weeks apart if that isn't the recommendation?
It's an excellent question. And so
These are given 2 weeks.
There's a recommended interval for Pfizer vaccine of 21 days and for the Moderna vaccine of 28 days. And, you know, it's almost going to be impossible to give people it right exactly on that interval. And so CDC in their clinical guidance did give a grace period of about 4 days before the recommended interval, where that could still be counted as a valid dose and wouldn't have to be repeated. Now, the studies themselves for the phase 3 clinical trials for Pfizer and Moderna both allowed those participants to get their second dose up to 6 weeks after their first dose. And so the clinical guidance from CDC now it states that as well, that the recommended interval is 21 days or 28 days, but that if you can't get it exactly at that interval, it is okay to go up to 6 weeks after that first dose and still be considered valid, a valid conclusion to that series.
But as far as you're aware, there's no data that suggests giving it 2 weeks apart is efficacious. And I wouldn't think that you would get the adequate immune response if you shortened the interval.
I agree with you. I'd feel much more comfortable with a longer interval rather than a shorter interval. And I don't know of any efficacy data that shows a 14-day interval with those mRNA vaccines.
Okay. Next question, any studies in children regarding vaccines and lower age groups? I've sort of seen in the newspaper somebody is looking at 12 years and older, but I'm not aware of anybody looking at younger children.
Yeah, so, you know, even when Pfizer applied for their EUA, they were already looking at kids down to 12 years old. They just didn't have enough participants at that time to make a good argument for including that whole age range in the EUA. Now they have more data from that age group, and they've extended their trials all the way down to 5-year-olds. And so For that Pfizer, they're looking at 5 years of age and up. For the Moderna vaccine, they're looking now at age 12 and up. And so those are the phase 3 clinical trials that are ongoing right now that we should have some data soon, and that they could then amend those emergency use authorizations if they've got good safety and efficacy data. I haven't seen any of those data. I haven't seen that any of those data have been released anywhere. But we're looking for it for sure.
Cool. And my last question that I've received is, can you restate the efficacy of the AstraZeneca vaccine?
Sure. So the AstraZeneca vaccine showed that theirs showed about a 76% vaccine efficacy after the first dose. And then when they looked at it with a 12-week interval, after that second dose, it went up to 82%. And so that was actually a pretty good vaccine efficacy looking at that extended interval in phase 3 trials from the United Kingdom. But that's from their trial data. They have phase 3 clinical trials going on here in the United States, and I haven't seen the data from the US yet.
And very lastly, are the mRNA vaccines contraindicated in patients with Guillain-Barré? I sincerely hope not, because I've had Guillain-Barré and I got my 2 doses of vaccine and I'm still walking and talking.
Good for you. No, it is explicitly not a contraindication. People with Guillain-Barré can get those. They did not see an increase in Guillain-Barré. I don't know that they saw any episodes of Guillain-Barré in their clinical trials, their phase 3 clinical trials, which were quite large. I think one of them had 44,000 participants and the other one 30,000 participants. But they are specifically requesting any information about people who do have episodes of Guillain-Barré after any of these vaccines are administered, because that's something they just want really close data on. And so VAERS reporting is encouraged for any sort of safety problems that you see or concerns that you have after administering a vaccine to a patient, but especially in the event that you see a neurological complication or something like Guillain-Barré.
Okay, well, that's all the time that we have, Dr. Schufert. Thank you very, very, very much for a very informative discussion. And I'll turn it back over to the moderator at large.